Thank you. And welcome, everyone. My name is Julio Robledo. I'm the project officer in quality improvement and reform here at the Brisbane North PHN. I'm happy to be part of the team that collaborates with external providers to bring you this type of sessions. And I would like to start today with an acknowledgement of country. So I acknowledge the traditional custodians of this land, the Turrbal and Jagera people of Brisbane, the Gubbi Gubbi people of Caboolture and Bribie Island, the Waka Waka people of Kilcoy, and the Ninginingi people of Redcliffe. I pay my respects to elders past, present, and future, for they hold the memories, the traditions, the culture, and hopes of Aboriginal and Torres Strait Islander Australia. So a little bit of housekeeping. This is an interactive session. Please keep your cameras open, your mics. We encourage you to have this interactive session with recap. Please ask as much questions as you'd like. Session is going to be recorded and shared with you in a couple of weeks' time. So please interact. I'm very excited to present Rivka. I mean, she needs no presentation. You've met her before. So Rivka, if you'd like to take it away, please do. Welcome, everyone. And let's have an amazing session today and have a really good participation.
Thank you. Thanks so much, Julio and the whole Brisbane North PHN team. Lovely to see you all. And as Julio said, Please turn on your cameras, and I'm absolutely welcoming your interaction as we're going to be talking about accreditation for the next hour or so. So I'd like to also acknowledge the traditional custodians. I am saying a hearty hello from Djadjurrung country in central Victoria, which is where I am located. So let me just share my slide deck with you so that you can see kind of where we are going with our conversation. So again, just to recap, this is an informal session. There's a fair whack of content that we're going to be covering off on. But if you've got a comment that you would like to make, or you've got a question to ask, feel free to just open up your microphone, interrupt me anytime. Very happy to have a little bit of banter as we're going along. The more you do that, the more engaging and interactive the session becomes. So let's get started. Like I said, we've got a whole heap of content to cover on all things accreditation. Now, as you'll know, accreditation is a big beast, right? Every 3 years it comes along, and there's a whole lot of activity that's going to come along with that. So I just want to caveat today's session by saying that we are not going to cover off absolutely everything to do with accreditation. There is absolutely no way that that can be done in 1 hour, but we're going to look at a bit of the overall structure of what the standards are all about, how you can demonstrate compliance, and then we're going to delve into the 3 modules that make up the RACGP standards, which is the core module, the quality improvement module, and the GP module. So on the slide, you can see here a little bit of the outline of what we're going to cover in the core module, and then we'll have a quick talk about a couple of elements out of both the QI module and the general practice module as well. I'm noticing a few of you are having a little bit of bite of lunch. That's absolutely fantastic. Drink your drinks, eat away. Like I said, it's a really informal session here today. So just do what you need to do. If you've got a camera, I would much prefer you to have it on and be present than to keep your camera off. And what that means for me is that I'm not looking at a blank screen, which is just awful as a presenter. So come and say hello. If we had more time, I'd go around the whole room and get you all to introduce yourselves. But let's get started on having a chat about accreditation. So what is this accreditation all about? What we need to understand is that practices that undergo RACGP accreditation need to kind of meet a definition of what a general practice is. And this was updated just recently this year. And it states that it is a health service, or a type of health service that operates within what is a prescribed model of general practice as identified by the RACGP, the Royal Australian College of General Practitioners. The services that you provide need to be predominantly of a general practice nature. And in essence, the proof of the pudding will be in the ability of any given health service to meet all of the mandatory requirements within the standards. So if your practice is able to meet all of the standards with sufficient effort, then you are very likely to be deemed a general practice. But more recently, the broadening out of the definition of general practices happened because there used to be a much, I guess, tighter definition of what a general practice is. And we know now that there are many GP type of services that have much more bespoke types of services, or they have a special interest or a sort of a slant towards a service or a certain service. And now the RACGP is saying, even if you are a special interest type of practice, that doesn't mean that you are not a general practice for the purposes of accreditation. So that change in the definition has kind of been a good thing to allow practices to find their niche markets and provide more bespoke services. However, it still needs to be underpinned by that notion of what a general practice is. So accreditation is really a cycle that never really finishes. It just goes around and around and around. And it is absolutely underpinned by the notion of continuous improvement. So the aim and the, I guess, the thrust of accreditation is to always be looking at and working on continuous improvement of your systems, your protocols, your ways of working, to improve the safety and services that you are able to provide to your practice and to your patients. And so what that means is that when you do come around to every 3 years when your accreditation visit takes place, the hope is that you haven't sort of squashed all of your activities into the last 6 months, but that this has been sort of an ongoing effort over time. So once your accreditation visit is done, that you don't kind of go, I don't need to think about this for 2 years, but you actually continue working on all of the elements that make your practice, I guess, compliant. But when you do come up to that 3-year mark and that revisiting of the more formal visit takes place, it starts with a self-assessment. So the practice will undertake a process of checking through each of the accreditation standards and doing a bit of a self-audit on how you are performing in that. And then once that's been done, you will end up with a survey visit. And that generally tends to be a GP and a non-GP visitor. You will know well ahead of the time when that's going to happen. A date will be set for you to do that. And then after the survey visit, it may be that you still need to show some additional compliance. It's very often or very usual for practices to have some areas where it's deemed that you haven't quite met the mark just yet. So you might need to provide some additional evidence or some additional information in order to tick those items off. So again, we'll talk a lot more about that as we go through the further slides. And then once the additional information has been provided and you've got the green tick in all of those criteria boxes, then your practice is deemed to be accredited for a 3-year cycle. You'll receive the certificate. You will very proudly hang that up on your wall. You will also include the certificate number now on your Proto account in HPOS. There has been just a recent change now too, where every accredited practice is given a specific identification number that you must put into your Proto, and that's linked to the Practice Incentives Program, which is often a very key reason why practices undergo the accreditation in the first place. So that's something new that you need to be looking out for as well. And once your practice is accredited, hopefully you fit back into that orange square there of continuous improvement, continue looking at your policies, your protocols, your ways of working, and keep improving at every step along the way. So at this point in time, we have 4 accrediting agencies that will accredit to the RACGP standards. The 2 most commonly known ones are ACPAL, which is based in Queensland, and secondly, QPA, Quality Practice Accreditation, which is based in New South Wales. However, there are 2 others, Global Mark and the Australian Council on Healthcare Standards. They came along a little bit later in the game, so practices are not quite as familiar with them as what they might be with ACPAL and QPA. But, you know, I think the important part to remember out of all of this is that each of these agencies, Amila, I might just get you to pop yourself onto mute. Maybe if you've got a question, you can type it into your chat box as well. That would be really helpful. So what's important to remember about each of the accrediting agencies is that they are all accrediting to the RACGP standards. So the standards are set and determined by the RACGP, not by ACPAL, not by QPA. Sometimes I hear practices refer to the ACPAL standards or the QPA standards, and that's technically not correct. It's the RACGP who's the owner and the setter of those standards. There are some differences between each of the agencies, and if you are coming into an accreditation protocol now, it would be worthwhile to maybe contact a couple of them, compare prices, and very importantly, compare what they do and how they can support your practice in getting ready for this accreditation visit. There do tend to be some big differences between the way different accrediting agencies support practices. So it's very important that you choose an accrediting agent or agency that matches your expectation and the level of support that you would like to receive in this preparation. Do they have resources available? Do they supply you with some templates? What else can they provide you in terms of education and training along the way? These are all really important factors together, of course, with the actual cost of the accreditation service. So then when we come to the surveying team, like I said before, it's usually made up of 2 surveyors. There needs to be at least 1 qualified GP to be on the team. And then the second team member is very often a practice manager, but it could be another sort of relevant peer. It could be a nurse, it could be an allied health worker, it could be somebody else, it could be an Aboriginal health worker, anyone who's got really relevant experience and skill in general practice. All the surveyors go through a training process, so you won't get anyone just sort of coming in cold from the street, coming into your practice and making some sort of assessment. So there's quite a rigorous process that's in place that forms the surveying team. When they come into your practice, they will usually spend about half a day at your practice. It depends a little bit. If your practice is a bit smaller, it might be a little bit less time. And certainly if your practice is bigger, they could be there for up to a full day. And they will go around and do their assessments of everything that you've gone through in the self-assessment and verify your self-assessment. So they are actually looking for the ways in which you are compliant to the standards. They usually don't come in with a mindset of finding fault and trying to pick the holes in what you are doing. So that's important to remember, and hopefully that will make you feel, I guess, a little bit calmer that this is not an exam, right? It's not like you're back at university or high school and all of a sudden you have an exam that you're going to pass or fail. It just doesn't work like that. Anything that's not quite right can still be rectified either on the day or after the day of the survey visit. Now, once the survey visit has taken place and the surveyors are wrapping up their assessment, they will report on their findings and report that back to the accrediting agency. And they will mostly give you, I guess, some feedback on the day as well. So there'll be like a finalisation interview or just a discussion on what the surveyors found, what they thought was really fabulous in your practice, and perhaps also the areas where they think that you may not have met the standards. And they'll discuss that very openly. What I would say is if you do find yourself in the position where the surveyors are indicating that something isn't quite met, but you don't think that's right, you should say so on the day. If they have maybe missed some paperwork or a policy or a procedure, or they've just not quite understood what your practice does and how it operates, you've got the chance to have that conversation right there, right then. And the surveyors will be more than happy to hear your feedback on anything that they may have missed in their assessment time. So that's one thing. Secondly, if they still think that it isn't quite right and you disagree, then you've got sort of that notion of natural justice, whereby you can challenge any of the findings from the accreditation team if you inherently disagree with that. And what happens, after the survey visit is that you will get a preliminary report that will outline all of the areas of findings from the day and outline where additional information or evidence is required. You'll then be given a period of time to supply that. And once that's supplied, that will be reassessed to ensure that that meets the requirements, and then you'll be issued with your accreditation certificate. So that's roughly speaking the process of what will happen after an accreditation visit. What we're talking about today is the RACGP standards for general practices. We're currently up to the 5th edition. And this set of standards is underpinned by a number of other guidelines and standards itself. So there's a QR code on the screen. If you're on your computer, you can certainly sort of zap that with your phone. What I will say too is right at the end of the session at lunchtime today, there'll be another QR code where everything that I'm talking about here is all together in the one spot. So maybe hold off until right at the end, and then you'll get all of the resources in one go. Now, the RACGP standards, it used to be sort of printed off in a book, great big PDF that you could, print off and bind up. I still have my paper copy because I really like working from a paper file, but all of the standards are available from the RACGP website, which is very easy to find, and you can navigate your way through each of the standards, the criteria, the indicators, and receive the most up-to-date information on where standards are currently at. Now, I also just want to flag with you that because the standards editions really live for a very long time, there are tweaks that happen along the way as well, and that happens roughly on an annual basis. There weren't any major changes to the actual core standards of late, but there certainly was last year. And so I really recommend that you keep a very close eye on the online standards, because that's going to be your source of truth. Whatever you print off, you need to make sure you overlay that with any changes that may happen from time to time to make sure that you're not working from now obsolete information. All right, so the structure of the standards then, as I sort of hinted at before, is they're it's a bit of a pie, and it's chucked into 3 components. So each third of the pie consists of the modules that make up the standards. So for general practice, it is the core module, the quality improvement module, and the general practice module. Now, for some different types of health services, it's that general practice module that might fall off and be replaced by a different module that fits in there. So, for example, if health services are after hours service providers only, they don't operate a more sort of traditional general practice, then that GP module would fall away, and in its place would be the after hours module. It will have a lot of overlap with what's in the general practice module, but it will be more bespoke to that type of service. So the GP module is the one that is flexible and interchangeable, but for today, we're just going to stick with the 3 modules as we see it here. Now, I'm just going to check. There was something in the chat box there. Oh, that was just about a connection, so that's not for me. Again, just let me know if you've got any questions or comments as we go along. So the standards are kind of, it's got quite a tree structure to it. It's quite formal in the way that it is presented. And the standards criteria and indicators have specific meanings as far as the RACGP standards are concerned. So the structure around this is that the standard in each module, so the core, the QI, and the GP module, are numbered. And what we've got in the core module is that there are 8 standards. In the quality improvement module, there are 3 standards. And in the GP, the general practice module, there are 6 standards. Underneath each of the standards are criteria that are numbered. And underneath each criteria, there are indicators, which are letters, A, B, C, D, etc. And then each of those indicators are flagged to indicate whether they are mandatory with a little blue flag in the book. I tend to use red flags in my slides. Anything that doesn't have a little flag next to it is not mandatory. So it's recommended. Have a look at it. If you can meet it, that's really great. But if your practice does not meet a non-mandatory indicator, it's not going to affect your accreditation status. What we do find is that any of the indicators that are not flagged or aspirational in one set of standards, in the next iteration of standards, they usually become mandatory. So often big changes will start from non-mandatory. We'd like you to have a look at this. And then 5 or 6 or 7 years down the track, when the new edition arrives, all of a sudden, it's no longer aspirational, it's an absolute requirement. So here is an example of the standard structure. So if we consider the core module, so that 1/3 of the pie, standard number 1 is communication and patient participation. That's it. It's a header. It's a chapter title to let you know what's going to sit underneath that. So underneath standard 1 on communication and patient participation is a criterion. So you can see here the criterion is called C for core module, 1 for standard 1.1, which is the criterion. It's asking for information about your practice as it relates to communication and patient participation. So again, you can see it gives you a little bit more guidance as to where it's heading, but it gives you no specificity of what's actually required under the criterion. And then we get the indicator. And here we've got indicator C1.1A, and it's got the little blue flag in there to say this is a mandatory one. And it states our patients can access up-to-date information about the practice. So it's the indicators that are being assessed, which then goes towards the compliance of the criteria and then the compliance of the standards. So it's the assessment of the indicators that is the grunt work of what happens on the ground and where your self-assessment takes place. Underneath each of the indicators is usually a very detailed explanation of exactly what is required, and often that is termed in the way of using language like you must, indicating these are the things you have to do in order to show that you are compliant with the indicator. Or it could use terminology like you could, which gives you a little bit more flexibility about how you go about demonstrating your compliance. But you put the musts and the coulds together and it gives you a really good idea of what do you actually need in order to be compliant there. And it will often also give you a very detailed rationale as to why this is important. And the why is really, really critical, because in the 5th edition standards, there is a lot more flexibility about how you go about meeting your standards. And I'll tell you a little bit more about that in a moment. So what we are talking about in terms of demonstrating your compliance is that there are 3 key ways in which the surveyors will assess your compliance. And it's on the right-hand side in that little column there, informed by interviews. So the surveyors are going to be talking to your staff. They're going to be talking to you as a practice manager. They're going to be talking to your nursing staff, your GPs, and your reception staff as well. Interviews, they want to hear, what do you know, how do you do, etc. They are going to line that up with the document reviews. So they're going to be looking at your policies, your protocols, and your records that underpin how you do what you do within your practice. And the surveyors are going to be looking for congruency between what they read as your policy and procedure and what your staff say they do. So they are not there to tell you how you should be doing, various aspects of your role, but they are looking to make sure that it meets the intent of the standard. The third way in which they assess compliance is simply by observation. So they'll be looking at your environment, they'll be looking at your layout, they'll be looking at your workflows, your computer systems, etc. So that's the direct observation that they will use as well. So this notion of the intent of the standard must be met is a really, really important one. And that's different from how it used to be in years gone past, where the standards were very didactic in terms of what you need to do and how you need to do it. What they realised, and by they I mean the RECGP and the standard setters, is that practices do things in different ways. How a small 1 or 2 GP practice operates is inherently different to how perhaps a large multi-site organisation runs. In the past, that meant that the standards requirements for really small practices were often really difficult to meet. There were very specific requirements around things like holding staff meetings. That was very sort of, I guess, determined how that needed to happen, even when that didn't make a lot of sense for the practice. where perhaps it was far more formal than what would be reasonably expected from a smaller organisation. And that's the bit that all changed when the intent of meeting the standard, when that was introduced with the 5th edition standards. So it is around the why of the indicators that you need to focus on and then interpret that along the lines of who are we as a practice, what's fair and reasonable and can be met with our resourcing and the way that we work. That's the important bit, which then provides you with some flexibility on the how. So flexibility is really good because, you have flexibility on how you do things. The tricky bit that introduces is that there is a lot more variability about how practices might be able to demonstrate their compliance. And for surveyors, that can be tricky to make that assessment of have they adequately met the intent of the standard. And this is sometimes where perhaps a little bit of argy-bargy comes into the conversation, but it's important that you understand that you do have a fair bit more flexibility now than perhaps what you would have in times gone past. So you've got to ask what works for your practice and then apply that. I might just pause for 1 second and see whether anybody's got any thoughts or questions on where we are now. Yes, no? No, I'm seeing some shaking heads. Kimberly, are you, no, she's connecting to audio, hasn't quite come through. Anyway, I'll let you just come into the conversation when you're ready. I also want to just draw your attention to the RACGP resource guide, which is a really fantastic resource, especially for newer practice managers or for new practices. If you are still sort of really looking at developing your systems and processes and you need additional guidance on how to implement the standards, this resource guide, you'll find that really, really useful. Again, my link at the end will give you access to that as well. And it is definitely available from the RACG website as well. All right, so we're now going to go and do a little bit of a dive into the standards. And I'm just going to pick out a couple of the indicators that I know cause some confusion for practices. Again, if you've got any questions, just come and join the conversation. So I indicated before that when we are considering the core module, so that first third of the pie, there are 8 standards and they are around communication and patient participation. Standard 2 is the rights and needs of patients. Standard 3 is practice governance and management. 4 is health promotion and preventive activities. 5 is clinical management of health issues. 6 is information management, 7 content of health records, and number 8 is education and training of non-clinical staff. So we're just going to have a very quick look at 3 of the standards, number 2, 3, and 6, and we're just going to do a little bit of a deep dive there. We're not going to touch any of the others. So remember, we are just taking a sample of them here. This is just not the whole suite of standards and requirements. So let's have a look at indicator C 2.1E. It's got the little red flag there, which means it is mandatory and it is around ethical dilemmas. Practices often struggle with that, going, oh, what do we need to do? What is this all about? So what is required of practices is that you must document ethical dilemmas that have been considered and the outcome or solution has been determined. So it's asking about documented evidence that you've considered ethical dilemmas. And it's giving a number of ways in which you might be able to meet that. And so the determination is that you might develop a policy or procedure that explains how the clinical team manages ethical dilemmas. You might have discussions at team meetings, and I think they're a really, really good idea to have some team conversations around what are the bits that sort of conflict us and that we find challenging. The standards also talk about a buddy or mentoring system for, supporting staff with different ethical dilemmas, group communication to pose common ethical dilemmas and perhaps what some of the solutions might be. And it also asks that we inform patients where ethical dilemmas are relevant to patients receiving services as well. So I've given just a couple of examples in the top right-hand corner of the slide there. So one really common ethical dilemma is practice staff attending the practice as patients as well. We know that generally there is a recommendation to avoid doing that, but there are some circumstances in which you might not be able to meet that, where perhaps if you're in a smaller town or you have a staff member with a very specific health issue that's been managed by your practice for a really long time, that would then cause this ethical dilemma of receiving my health care at the place where I work as well. So the standards do not tell you what is the right outcome. Very clear about what ethical dilemmas are all about. This is not about telling you what's right and wrong. It's about giving you a framework for working out what's right or wrong for your practice. Another example is the giving of gifts. So, we might say that a box of chocolates at Christmas time from patients is acceptable. However, if someone comes with a gift of, $2,000 for a specific staff member, that would not be okay. So again, a discussion around where are our boundaries? Again, the boundaries are not defined. It is what is right for your practice. And another example is the provision or the denial of specific services. So that can crop up, for example, when there might be religious or cultural objection to the provision of certain health services by some healthcare providers. Again, there is nothing wrong with that, but it is how do you navigate the ethics of that, and how do we ensure that patients are able to access the services that they are entitled to when some of our practitioners are unable to help that. So again, it's about what happens in our practice, how do we inform patients when that happens, and how do we how do we deal with that? So again, if we had more time, I could spend a good 15-20 minutes just on this topic alone, but that's the kind of information that you need to keep as far as ethical dilemmas is concerned. I think it's a great idea to introduce ethical dilemmas as a regular standing item, perhaps not for every team meeting that you have, but at least maybe a couple of times a year. It might be around orientation and induction for new staff to say, hey, if you see or observe anything within our practice that you think is a bit conflicted, talk about it. Let us know so we can add it to our discussion items. So openness and awareness as a first point. That would go into your policies and procedures, and it would go into your induction framework. That's one way you could do it. You then go and have those conversations and discuss amongst the team, where do we sit? What do we think? Where do we land on this? And then we need to record what the outcome of that is. So whether that develops into its own policy or procedure is going to be entirely dependent on what the scenario is. But you might also keep a little bit of a register of what are the ethical dilemmas that we've identified and how do we respond to them. A register is great. And I think of a register as an Excel spreadsheet. And those of you who know me will know that I'm a bit of a spreadsheet nut because I think it's so useful for so many things. But if you keep your ethical dilemmas in a spreadsheet, then it makes it very easy to not write, 5 pages on an ethical dilemma, which nobody's got time for. But it does allow you to go back regularly and just recap and go, is this still appropriate? Has anything changed that we need to keep an eye on? So keeping a register, again, is also a really lovely way by which you can demonstrate your compliance for the purpose of accreditation. That's enough about ethical dilemmas, I think. Let's move on to course standard 3 around practice governance and management with criterion C3.1 around business operation systems. There are 4 indicators that sit underneath this criterion. So there's A, B, C, and D. And you'll see that B hasn't got a little flag next to it. So B is still non-mandatory at this point in time. So this is how these indicators read. Indicator A, our practice plans and sets goals aimed at improving our services. That's good. That's great. Indicator B says that our practice evaluates its progress towards achieving its goals. Now, that's the bit that's not yet absolutely required of you, but I'd be saying if you're not reviewing your progress against your goals regularly, then you're only just starting on this process. I think it's a really, really important part of goal setting and improvement planning that you regularly look at that and review it. And what I said about the ethical dilemmas just before applies equally here, right? It's the same kind of process of setting a goal, setting an action, identifying an ethical dilemma, and then reviewing that after a period of time. Indicator C is our practice has a business risk management system that identifies, monitors, and mitigates risk in the practice. Really, really important. The surveyors will absolutely focus in on this, because if we remember back to why are we doing these standards and this accreditation in the first place, it's about minimizing risk within our practice, both clinical and non-clinical risk, and improving the safety of what we deliver to our patients and the effectiveness. So risk management really underpins many areas of the ROC GP standards. And indicator D, you need to have a complaints resolution process. So those are the requirements there. So if we just sort of hone in on the risk management and what you might be considering there, there's a few items there. So record keeping and communication. So this is mostly to do with GPs and health records management. Near misses, mistakes, and adverse events. So that is also reflected in the quality improvement module as well, in criterion 3.1 indicators A and B. You need to be thinking of all of the sorts of clinical risks that your practice might undertake. And, I know there's a few familiar faces in the room that I know we saw just a couple of weeks ago when I was in Brisbane, and we spoke at length about risks in primary care. So you'll remember that from there as well. So clinical risks, I would also really encourage you, if you're thinking about risk in your practice, to also think of financial risk. Now, I've added that one in, but it is not strictly one that is included in your RACGP standards. I think just from the practice perspective, if you're doing a risk register or you are embarking on risk management, if you're not including financial risks in that, you're missing a really important part of risk management for your business rather than risk management for the purpose of accreditation. So think about your business viability and financial risk. It's really important. Computer systems, privacy, consent processes, workforce planning, Medicare changes. So these are all areas where things change very rapidly, and they do provide high level risks for the practice. So the higher the risk, the more focus you need to put in to mitigating those risks and minimizing them wherever you possibly can. In Core Standard 3, we also need to consider an emergency response plan. So this is a fair whack of work for most practices to develop the very first one. And I highly recommend the use of the RACGP Emergency Response Planning Tool. Now, I'm not sure whether the PHN actually supports that. I know there were many PHNs over the years that actually helped to pay for this resource. It's not a free resource, but I would recommend, even if the PHN doesn't support it any longer, well worth the investment for the practice to just take out a subscription to the RACGP Emergency Response Planning Tool, because it will guide you all the way through emergency response planning. Don't start that a month before your survey visit, because there's a lot of information that you will want to put in there and capture there. You need to have a plan, and certainly the ERPT does that, for emergencies such as natural disasters, pandemic, disease, unplanned absences of clinical team members, and a whole lot more. These are just a couple of examples of what goes into that emergency response plan, and it's important that you have that available. Also in Core Standard 3 around practice governance and management, are standards and indicators around work health safety, supporting the practice team on health and well-being, and the practice team is encouraged to obtain immunisations recommended by the current edition of the Australian Immunisation Handbook based on duties and immunisation status. Again, this is a pretty beefy part of the RECGP standards as well, so make sure that you have a closer look at all of the requirements there. As far as staff immunisation is concerned, we need to make sure that we have informed consent from our staff to access that information about them and that we are permitted to keep it. So we are looking at immunity to vaccine preventable diseases, and immunisation status of the practice team members is currently known. Now, this is an interesting conundrum because there are some changes happening where the requirements for privacy provisions are now intersecting with this notion of being transparent about immunisation status. So weighing up the privacy provision, especially for staff members, versus the practice's desire to have that information available for safety. I'm hearing conversations that there is more happening in that space where we need to step very carefully around consent processes. So I am hearing of some practices or some health organisations now no longer keeping within records of personnel their immunisation information for the purposes of maintaining privacy. And that kind of flies in the face of what the RECGP standards are requiring of us. So I'm encouraging you to just keep your eyes open on any changes to the wording that may come up in this requirement for immunisation status being known to the practice team, as is currently stipulated in the RECGP standards. What you do need to make sure of, though, is that regardless of what information you keep, that you offer adequate immunisation for team members based on their duties. And by team members, we are not just talking about direct staff of the practice, but also others who regularly intersect with the team. So you might think about, for example, allied health or specialist visitors to your practice. It might be around cleaners or other associated entities who may be impacted by, by these requirements. So in terms of the recommended immunisations, it is all there in the NHMRC guidelines, the Australian Immunisation Handbook. And there is a requirement for all healthcare workers directly involved in patient care or handling tissue where the recommendations for immunisation are listed there: COVID, Hep B, influenza, pertussis, MMR, and varicella. What you also will need to have a bit of a think about is that there are some specific risks that might warrant some other vaccinations as well. So you need to consider, does that apply to our workplace or does it not? And a couple of examples there: Hep A, and BCG, tuberculosis type of immunisation or testing may be warranted as well. So if you're kind of going, oh my gosh, I don't know too much about this, go back to the Australian Immunisation Handbook, and all of the details are in that. That is available online as well. So again, make sure you're always at the most current edition of that information. For Core Standard 6 on information management, it is around confidentiality and privacy of health and other information. There is a lot in this. Now, time's kind of running out already today. We could spend a session just on this topic alone. And that's the reason why I guess I'm landing here, just to flag with you, look very closely at privacy of health and other information, because it's a really big deal as far as the standards and your legal responsibility is concerned as well. So indicator A, patients are informed of how our practice manages confidentiality and their personal health information. And it is underpinned by a whole raft of legislation and frameworks that you need to be familiar with and you need to adhere to. So again, if this is reasonably new to you, you've got homework to do to become familiar with all of the requirements that underpin this. So you need to understand the Australian privacy principles, the APPs, which are contained in the Privacy Act. There is also fantastic information available from the Office of the Australian Information Commissioner on health privacy principles as well. So heaps of resources available there. And, it's underpinned by legal requirements. So not just accreditation, but, you need to not break the law, which is, of course, really important. And any other sort of relevant state or territory laws that might apply to, to Queensland as well. So you've got to be across all of that, and you need to respond to that in the way that's outlined in the RECGP standards and all of those various underpinning legislations as well. Okay, and again, I'm very aware that was a very quick fly through, as will be the rest of the standards and indicators that we're going to just chat through now. So onto the quality improvement module, that second part of the pie, 3 standards around quality improvement, clinical indicators, and clinical risk management. So those are the 3 standards. We're going to just look at standard 1, criterion 1.3 around improving clinical care. So indicator A, not flagged, so not mandatory. Our practice team uses a nationally recognised medical vocabulary for coding. So this is around condition coding within your health records. From the RECGP's perspective, it's not mandatory, but guess what? It is for the purpose of your participation in the eHealth incentive, in the practice incentives program. But what you can see too is that there is overlap between the RECGP standards and the practice incentives program as well. So clinical coding is required if you are tapping into the eHealth practice incentive. The clinical coding, the language that's used, or the vocabulary that's used will depend on what practice software that you use. And an example that they give in the standards in the outline there is that you might use an example, use your practice management software to code patient health information. Well, that is kind of what you would do. You should have access to clinical coding software. And your doctors need to be trained to use it consistently, and you should have a pretty good feel of what that looks like through your data dashboards that you get from your quality reports as well. Another example, keep clinical data and reports, childhood vaccinations, completed adult health checks, and updated risk factors. So this is just suggestions that you will read through when you read through the RECGP standards. You might also maintain some sort of register, which is to do either with PenCat or Polar or any other data extraction software that your PHN uses. I think for you guys, it might be Primary Sense, if I'm not mistaken. Yes, I'm seeing a nod from Jennifer there. Thank you for confirming that. So that also feeds into this requirement here. Now, indicator B is the one that is mandatory, so that's flagged. And it says our practice uses relevant patient and practice data to improve clinical practice, for example, chronic disease management and preventive health. So isn't it funny, right, that indicator B is mandatory, but the way in which you would be able to do that, i.e. indicator A, is not mandatory. So by default, it actually makes you do A so that you can do B as well. And so I guess what the standards are asking you to do here is to actually look at your data and then plan your service provision in accordance with what that data is showing you. So you need to show some evidence of that when your surveyors come to visit you. Around patient feedback, again, there's a myriad of ways in which you can do that. You could develop your own questionnaires, and if you have interest in doing that, the RACGP has further guidance available on that. You could use focus groups or interviews. There are not many practices who choose to use that method of providing that sort of validated patient feedback because it's quite sort of person intensive in that it takes a fair bit of time in order to get focus groups together, to pose questions to them, to gather that information, to interpret it, etc. But if you're interested in doing that, again, the RECGP guides will have additional information for you. You need to undertake formal patient feedback at least every 3 years. But I would really encourage you to look at a way of tapping into continuous patient feedback. It doesn't need to follow the guidelines specifically of what's required for that formal feedback once every 3 years. But for me, the day-to-day feedback that you get from your patients is not is possibly even more valuable for your practice than the once every 3-year activity. So think about how you might do that. You know, in the years gone past, practices might have a shoebox in the waiting room with a little hole in it and little chitties where patients could write their little notes and throw them into the box. I think we've got better ways of doing that these days, with almost everybody having smartphones and the like. Create a QR code, do an online form, and ask a couple of simple questions. How did we do today? Did we meet your expectations? Is there something you'd like to tell us? Make it quick, make it simple, and encourage continuous feedback, and then ensure that somebody looks at that feedback as it comes in and responds to it. Fabulous marketing process as well. But this is kind of setting a little bit away from what the RACGP actually requires of us, which is just that formal once every 3-year type of process. Once you've undertaken the feedback, you need to share the outcome with both your internal team as well as with patients. So it's not enough to just run the patient feedback survey. You need to look at the results and make some decisions about what you're going to do as a result of that feedback. That's the bit that the surveyors are going to be much more interested in than understanding whether your patients are complaining about your waiting times or not. It's your response to that that will determine your compliance to this particular indicator. And then obviously note down what actions you've taken as a result. And then we're just coming into the last module, the general practice module. So there are six standards there: access to care, comprehensive care, qualifications of the clinical team, reducing the risk of infection, the medical practice, and vaccine potency. Now, I was going to originally talk a little bit more about vaccine management, but I've changed my mind. I'm going to talk a little bit more about reducing the risk of infection, because there have been just a couple of changes of late that I wanted to bring to your attention there as well. Okay, my first point on all of this is that prevention of infection within your practice is a really key area of responsibility, and it is high risk. So land there, spend a good amount of time on your practice's response to this, because it's really, really important. So the areas that it covers are around hand hygiene, personal protective equipment, aseptic technique, precaution levels, staff immunisation and protection, sharps and sharps exposure, cleaning laundry and waste, instrument reprocessing, disease surveillance and outbreak response, and planning a practice or design considerations. And that's the bit that I kind of want to lean into as well, because there have been just a couple of changes there as well. As far as reducing the risk of infection is concerned, that is underpinned by its own set of guidelines. There's a little picture there in the top right-hand corner of what the resource looks like. There is a URL there. Again, you'll get all of that in the one-stop shop at the end of today's session. But this was updated in June this year, so only a couple of months ago. And it has now included much more detail around designing and redesigning treatment rooms. And we'd really encourage you to just have a look at that if you are in the process of planning any sort of new clinical area, that you've had a really good look at these design recommendations, because, you know, once your sinks are in and once your infrastructure's in place, it's really, really hard to change it. So have a good look at that. So the requirements for pre-cleaning for reusable instruments. There have been some changes there too, and that's causing a little bit of confusion as well. So the question that was posed to me just recently was around ultrasonic washer disinfectors. And the question was, is that now mandatory? And the response to that is no, it's not yet mandatory for you to have an ultrasonic washer disinfector if you are reprocessing instruments on site. So for practices that only use disposable instruments, this isn't something that you would need to worry about at all because you are disposing of your instruments. So it's the practices that do on-site autoclaving or the practices that send the instruments to another facility for autoclaving. There is a high recommendation, though, that ultrasonic washers are best practice for pre-cleaning instruments. And that's why this has now been included in these guidelines to really strongly encourage you to consider that if you are reprocessing instruments. Now, the ultrasonic washers do require performance monitoring and validation. So it has its own maintenance and validation process that you have to adhere to. And that's important. So think about the cost of acquiring and then the time and effort involved in actually maintaining that equipment as well. If that's not an option for you, or if you are maintaining sort of manual cleaning processes, the recommendation is for 2 sinks if you are manually cleaning, where you need to have a dirty and a clean sink. So the separation of them is deemed to be really important. Now, many practices have traditionally sort of used where they had only one sink available, they would use like a tub as their dirty sink and then the sink for the clean sink. The assessments on that from the surveyor's perspective is just becoming more critical as time goes by, because that's now been a recommendation to have clean and dirty sinks, so separation of sinks for a long time. You're going to get more pressure put on you if you only have one sink available for washing instruments when you are reprocessing. And then you would really want to be considering, I think it's time to really look at an ultrasonic washer, rather than a tub and a sink, etc. So think where you are in that process and consider what investments you might need to make or what changes you might need to make that kind of work well. You do need a separate sink for hand washing. So the dirty and clean sink are not to be used for hand washing. That needs to be a separate sink. And if that's not possible, you need to have access to a hands-free hand rub. So this is a dispenser for, a hand disinfector, whereby you don't need to use your hands to dispense it. So no pump packs. It would need to be sort of like sensor-based type of dispenser, so that disinfection of hands can happen in the way that it is expected. So that's been sort of the newer instructions that have been included in the newer guidelines. And oh gosh, we are right on the hour. I knew that we would cut it pretty fine. Just to recap, we have not covered everything. Absolutely not. So I hope this is kind of gotten you enthused to look more closely at the standards if you haven't already done so. Start preparing early. Consider that accreditation is a whole of practice team activity, not just a practice manager activity. So delegate is the way to go. I also want to just advise you of the next Lunch and Learn will be on the 23rd of October, so in about a month's time, and that will be on developing nurse-led clinics. So it's a slightly different focus from what we're talking about today. We'll look at the sorts of processes that you might want to put in place to develop your nurse-led clinics, including finance and budget planning to ensure that your systems are viable or your new service is viable, the education, training and resources that you might put in place to help these team-based clinics along, how you might go about marketing and promoting your new service, and then implementing and reviewing your clinic. So again, there'll be a fair whack of content in next month's Lunch and Learn, but hopefully we'll see you for that one as well. And then lastly, there is a URL. That's the one that's going to give you the keys to the castle of all the bits and bobs that I have just spoken to you about. If you can zap that with your mobile phone, go ahead and use the QR code. If not, you can use the URL link that's in the top box, the little orange one there. And through that link, you will get access to all of those standards, the resource guides, including security in general practice, Strive for 5 to do with vaccine management, the business planning guide, the patient feedback guide, frequently asked questions, and there is some more information on other registers and tools that you might be interested in to help you gather all of your evidence and keep it in an easy to use format. And that is about it for now. I'm itching
Thank you
for
so
some
much.
questions or some comments. That's what I would like. Thanks,
Yeah.
Elio.
Yeah, the expression of interest for the session in October is going out soon. So keep an eye for it in your emails. We're going to be sending an EDM, and it's also going to be coming out in Practice Link. So keep an eye out for it. You know, you have to sign in, and we then will have a selection process and everything. But yeah, keep an eye out for it. You beat me to the punch there. So thank you so much, Rivka. Thank you so much for this session. Please do ask questions. I know this was quite an intensive session, so this is your opportunity.
I've still got some spare time. So if anybody is kind of now going, now let me ask you, if you've got some questions about anything to do with the standards that you want to have a bit of a natter about, like, this is your forum. So, you know, come talk to me is what I would say.
And also we have some of our engagement officers present. So also, if you have any questions, there are also people who you can reach out to if you would have any other questions. So we have Rivka, we have our engagement officers, and I think Jen, you want to say something? So please go ahead.
I did actually. I wanted to ask Rivka a question about the survey, because it's been a little while since I went through accreditation. Rivka, is there now, or is it becoming acceptable to use online forms of surveys, for example, SurveyMonkey and other tools to do that?
Well, certainly for your informal and ongoing feedback, absolutely. I would say use whatever is helpful for the practice. So there is no stipulation of what that might look like. Okay. But there is that validated feedback that does need to take a specific form, and that's all in the RACGP feedback guide. So mostly what practices do is they actually purchase the commercially available validated tools like what you get with CFEP and InSync and the like. There is a bit of cost involved in that, but practices generally find that a simple way to go. You'll be given, you know, the paper forms, and the practice needs to issue that out to patients. Then you wrap it all up and send it back for that analysis bit. And then that comes back to the practice with the actual report, and then action needs to be taken on account of that report. So that's one way of doing it. And remember, you know, there are focus groups that could be done. Or if you are so inclined and you want to avoid the cost of the commercial products, you can develop your own, but there's a fair bit of work involved in that, because it needs to become what they, you know, a validated feedback process. So that validation process will require a fair whack of time of the practice manager to make sure that that actually meets the requirements, and then actually implement it. So, you know, on a cost basis, I'd say it's not likely that you're going to come out ahead by making up your own, but there could be good reasons why you want to do that. It might be, you know, your location or the specific service focus that you've got that makes the general validated feedback a bit sort of nonsensical. And I do know that over the years, you know, many practices have kind of complained that they find the validated patient feedback survey not that user-friendly. It's long, and often patients don't answer it really well in terms of they provide contradictory responses. And then what do you make of that? If it's so convoluted, then what's the real value in that? So there's a lot to unpack as far as feedback is concerned. But yeah, you know, I think SurveyMonkey would be a great idea. Microsoft has Microsoft Forms. Google has Google Forms. Lots of different ways in which you can seek that feedback, but I would really recommend on an ongoing basis, it's got to be short, right? Not 20 questions. You know, people are sick of evaluations, aren't they? They just want really, really simple, even just a smiley face, just rank it. Was today good, great, bad for you? And that's going to tell you a lot about what's going on a day-to-day basis.
So we have some comment from Leanne Dixon. She said that they use CFEP and they have online links now. So that could be an also tool. Yes.
There you go.
And,
so
And
They're
you
all
know,
moving.
funny enough, you mentioned the survey because I actually did not mention that at the end of this session, there's going to be a survey popping up. So please do answer the survey. That survey is really useful for us to see if you like the sessions, what type of sessions would you like to have in the future. So that feedback really does help us as a PHN. And it's also for you guys. So because we're tailored these sessions to your needs. So please do answer the survey. And is there any other comments? Is there any other questions? This is your chance. You have a one-on-one with Rivka. It's a once in a lifetime opportunity. So anyone else? If you don't like to speak up in the camera, you can type it in the chat. Otherwise,
Absolutely.
we could end the session soon. So we'll give a couple of minutes for the participants.
Terrific. Well, I'll hang back a bit, and whoever needs to dash off, feel free to do so. I think your survey will then pop up for the evaluation. And yeah, I'm happy to hang around for a couple more minutes and see if there's anything else that comes up.
Well, thank you everyone for joining the session. We'll wait here for a minute or so, see if there's any other questions. If not, please reach out to your engagement officers. They're also wealth of knowledge, so please do. And if anything else happens, we also have practice support. So here we are for you. Thank you, everyone.
Okay, I think we're just getting some questions. Okay, Rachel has just posted a question to me directly. Rachel, I might just encourage you to, you can contact me through the URL that's given as well, but that URL also gives you the information about the register that you are asking about. I'm presuming it may have something to do with the practice managers workshop from a couple of weeks ago. So I think the answer to you will be yes, that's fine. So get in touch with me and we'll make that happen. Okay, so I'm hearing a mouthing of a thanks. I think I understood that one correctly. All right.
Well, I think we can finish the session then if there's no other questions. So thank you, everyone. Again, if anything happens, please reach out to us. I'm more than happy to help and answer your questions.
Fantastic.
Okay?
Thank you so much. Take care.
Thank you so much, everyone. Have a good day.
Bye-bye.
Thank you, Rivka, for everything. Really appreciate
No
it.
worries.
Should we start the session then?
Yeah, probably best to. Sorry.
Yeah, no worries.
Best laid plans.
No worries. Well, welcome everyone to this second session in accreditation. Should we start the session then?
Yeah, probably best to. Sorry.
Yeah, no worries.
Best laid plans.
No worries. Well, welcome everyone to this second session in accreditation. Session in accreditation. Oh, thank you. And welcome everyone. My name is Julio